morning and for your interest in asthma disparities in public health. My name is Sally Haack and I'm on faculty here at Drake in the College of Pharmacy. I also have with me Andrea Kjos, she's another faculty member in the College of Pharmacy. And we have Claire Richmond, and she comes to us as the project manager for Healthy Homes Des Moines. And then we have Carolyn Schaefer on the end there. She works with Polk County Health and is the coordinator with this project. And then finally we have Kiersten Cooley, and she works with Visiting Nurses Service. So for our time together this morning, what we plan to do is Andrea and I will get us started with a little bit of an introduction about asthma itself and talking more specifically about some innovative methods that have been used in the research world in examining health disparities in public health. And then we'll highlight one example that has been used in Michigan to combine and collaborate community partners with research institutions to improve public health outcomes. After we set that stage and get started, then I'll transition over to our community partners, and they'll talk more specifically about the Healthy Homes project here in Des Moines. So how this relationship came about, I guess, is over the past year or so, Andrea and I have been working on some initiatives and exploring some opportunities related to asthma disparities in the community. And this spring, I think, maybe in February, we attended an event here in the community and learned about Healthy Homes and got in touch with the partners that we have here today. So hopefully we'll have more collaboration and partnerships in the future too. So just a real quick one slide about asthma. We know it's a really common airway disorder. And a lot of times when we think about asthma, we consider the environmental triggers that play a role in uncontrolled asthma. So whether that's smoke or other pollens or irritants or chemicals, occupational exposures, but we might not think very much about the socioeconomic factors that are involved or even genetics that also play a role in asthma. Asthma impacts not only, of course, the individual themselves or the patient, but also the community around them. So if their asthma is uncontrolled, they might have missed days at school or missed days at work. They might have lost productivity. Also, the inability to really do their activities of daily living or participate in activities, especially for kids that they want to in school. So this disease state has a lot of opportunity for us to make interventions, not only related to medication therapy, as the pharmacists think about, but also education to patients and their family members for reducing those triggers, and then also thinking about other ways that we can contribute to improve asthma outcomes. So just two quick slides on asthma across the U.S. This first one is related to asthma prevalence. And so what we have here is the percent along the bottom. And you can see for children in the U.S., about 10% or so have asthma. So that's a more prevalent condition in kids than compared to adults. And then moving down, I know this is very small to see, but it breaks it down into patients as far as white, black, Asian, multi-race, and then Hispanic. So you can see that the Puerto Rican population has a much higher prevalence than some of the other populations, as well as those that identify as multiracial and African American. The bottom section there also lists poverty. So you can see that asthma is more prevalent in those with lower incomes as opposed to those with higher incomes. For those that do have asthma, then we look at their asthma encounters in the healthcare system. So here you can see that the light blue bars at the bottom represent physician office visits or hospital outpatient visits, which are the most common across all demographics. The ER visits are the darker shade of blue, and then the hospitalizations are the darkest kind of navy blue colors. So here you can see that children access the healthcare system quite more prevalent or more frequent than adults. And then if we look more closely at the black population, even though the hospital or the physician office visits are about the same as their white counterparts, their number of ER visits and hospitalizations is quite a bit larger than their other counterparts. We're specifically drilling down to our local state here in Iowa. Again, this is very small, but on the bottom left, we see how Iowa compares to the US as a whole with the rate of asthma in children. So the red line is the US change in prevalence of asthma in children over time, and the blue line is in Iowa. So you can see that although it has gone down in recent years, it's still higher than it was a couple of decades ago. I'll also highlight on the right-hand side here, again, this is Iowa data, the white population compared to African American population, and the number of ER visits. So on the left side, we have 0 to 17-year-olds, with the red bar being black patients, the blue bar being white patients, and it was 6.6 times higher, the rate of ER visits in black patients versus white patients. So not only the prevalence is impacted in asthma, but the control of the asthma, the number of exacerbations, the number of times they're utilizing the healthcare system is disproportionate, and there's a disparity here that exists. So you might be thinking to yourselves, why does this happen, and how can we research this or look at this to understand the dynamics or the different components that play a role in the outcomes and make interventions to improve the health of our patients. So I'm going to turn it over quickly to Andrea to talk more about that.
All right, now that you have a little bit more of the incidence and prevalence of the information of the disease itself, I'm here to contribute more as a social scientist and look at this truly as the complex illness that we see in terms of those differences of prevalence in our population, and thinking it about asthma critically in a social context. So what I mean by that is that we can really look at asthma in a couple of different ways in a social context. I've kind of split it into two, social environment and then the physical environment. There's been a lot of discussion in the literature about, okay, well, we know that there's a big disparity on the racial disproportionate number of people that experience asthma, as well as from socioeconomic standpoint. A lot of people say, okay, we can grasp onto that component about the physical environment. And that's something that a lot of people in the public health sector have gravitated towards because it's something a little bit more tangible and practical that we can fix. And then our friends here from the community are going to talk a little bit more about the dynamics that go into that practical application of improving the physical environment. So think about hazards in the homes, neighborhoods, and the environment of communities where people actually live and work and play. The other part is the social environment in terms of thinking of specifically to race, also breaking it down a little bit further into sort of the family level components and the community level components. These are maybe outside just the sphere of the physical environment of the house itself, but thinking about what sociological stress is happening for patients and families, so exposure to acute and chronic stress. Absent of social support, so how readily available do patients have access to primary care, to pediatrician care, things like that. Also anxiety and depression. There's been some interesting studies that have really tried to pick this social issue apart a little bit further and have found that where families with caregivers that have increased levels of depression and anxiety, the adults, the children actually have higher levels of asthma exacerbations and higher level of disease. So there's really something there to that social environment that goes beyond just the housing itself. And I think social scientists are trying to tease that out as far as what is it about that social environment that might trigger patients to have higher levels of exacerbations in their illness. And then also this community level, what's been called in some of the social public health circles as the neighborhood disadvantage. So again, going beyond the physical environment, thinking about unemployment, violence and crime, things where people just maybe don't feel safe and don't feel secure. Their future is very unpredictable. And so maybe that ties back to thinking about sociological stress as well. People have talked about limited social cohesion. And I think there was some interesting research that tried to pick this issue apart a little bit further. And what they did was they took people that were sort of in neighborhoods that were socially disadvantaged, maybe in public housing, maybe not necessarily hazardous housing, but just maybe in a community where nobody knew their neighbors, people felt maybe unsafe. And they actually gave those people in the research study vouchers to obtain private housing in the suburbs outside of maybe their disadvantaged community. And what they found was a drastic reduction in asthma exacerbations for those children. And so again, they held constant some of the variables that you would think might be explaining that, such as the physical environment itself. And so we know it goes beyond just that. The social environment component of the expression of asthma seems to be very, very complex. And so where does that leave us as far as social scientists? Well, the next step for research is really trying to figure out how can we address the community itself, and then also think about how these social components interact with biology and physiology, because there's some sort of interplay that's happening there, so we are not exactly sure when the social component sort of triggers, if you will, maybe triggers not the best word, over into the expression and the physiology of the disease.
What does it mean, socioeconomic status added by race?
So when public health researchers study sort of the disparity of asthma, usually they say that you can think of race and ethnicity separately from socioeconomic status, which is usually measured in terms of income. You can measure those things separately and see asthma disparities. So if you're a racial minority, you will have a higher incidence of asthma in your community, especially in children. If you are economically disadvantaged, even as a white person, you will also have a higher level of asthma exacerbation, especially in children. But if you have both of those things together, it actually exponentially increases your risk for asthma exacerbation in children. So that's a good question. So the comment is we don't really kind of understand that interplay. Why is there such this exponential increase? It's not 2 + 2 = 4, it's 2 + 2 = 15. And so that's why asthma has become such a big quandary for people to really look at in research. So that's a little bit more about the social context and thinking critically about what are the factors that go into the prevalence of this condition. Some work has really been able to sort of crack this nut, if you will. And what they're doing is they're taking it one community at a time. And this approach is known as community-based participatory research, or CPHS. This is an approach to research that takes generalizability sort of out of the equation. And so it really makes the research question from even inception come from the community itself. And so I've listed here in this slide, I know it's kind of hard to read in this room, the 9 tenets or the 9 framework foundational elements of this approach to research. And what people are finding is if we take a very complex manifestation of an illness with all these social sort of layers that go into making it worse, if we can sort of start to peel that back a little bit by thinking about what is the community, what are their needs, what are they experiencing, what is it about the environment that might be contributing to this, and really making the community part of the solution, then they're able to find some real solutions that are both practical and effective. And so this is really an approach to kind of solving this quandary in healthcare. It's a public health approach, and it's one that we've had some interest in sort of developing here in the Des Moines area. I'll just highlight one quick example because this is how I was introduced to this approach to asthma disparities in public health. Community Action Against Asthma is an initiative that began in Detroit, Michigan, and it has been sustained since 1995. And I'm sure many of you are familiar with what sort of happened in Detroit in recent years with their economic crisis and really sort of the downturn of sort of the conversation of the housing market and things like that. But this has really been a flagship in terms of community-based participatory research in addressing asthma, because asthma was such a problem in many of the neighborhoods of inner city Detroit. And they were just like, how are we going to address this? This is a major public health problem. And they brought together community partners, they brought all the stakeholders into a room, and they figured out practical solutions to try to help address this. Two examples of the projects that they've done in this area, one I just had mentioned here called the Nexus Project, was where actual scientists went in and measured air particulates related to vehicle emissions, because many of the neighborhoods that they were finding this problem with, there were major highways just within feet of some of these neighborhoods, and so the chemical emissions of the environment, and they had hard data then to sort of show how sort of rezoning some of those major thoroughfares could really impact health. And so they took that data forward to then government officials to actually reroute some of the major thoroughfares through the inner city areas. So that was one really successful example.
Does the project address some of those social factors?
Yes, so they've done a number of different projects, but yes. So in the second one down here, the household air filter intervention that they did, one of the first things that they did, one of the first interventions that they tried was just educating people, educating families, sort of getting nurses and getting care workers into homes. And what they found was perhaps the issue of the air quality, maybe the road situation wasn't a direct impact, or maybe the housing situation couldn't immediately be addressed in terms of the hazards within the house itself. And so they tried just sort of this approach using air filters, small air filters that could be easily installed, and they showed an amazing impact for just implementing small air filters in the homes as a one way to address problems with families. So this is an ongoing initiative in Detroit. How I found out about it was they actually came to the University of Iowa last fall for a conference to kind of share their findings. So all these years they've had dozens and dozens of publications on this issue, and they really presented their work and talked about sort of best practices and lessons learned. And so I went to that session at the University of Iowa and met with the leaders of this initiative, and it was really inspiring to hear how much they've accomplished and how many people they've been able to bring together on this one issue. So I wanted to kind of bring that as kind of a foundational example that we can kind of aspire to. So that kind of gives you some groundwork for understanding this complex problem a little bit more. I would now like to turn it over to people that have really been working on the front lines of this issue in the community. And I believe Claire is going to go next to talk to you a little bit more about Healthy Homes Des Moines. Thank you.
Thanks, Andrea. Okay, let me make sure that this is working here. Oh. Okay. Hi, everyone. My name is Claire Richmond. I'm the project manager for Healthy Homes Des Moines. And that was a really great introduction into some of the things that we're looking at with our program. So similarly to the program in Detroit, we're doing a Des Moines-based intervention that's kind of tailored to some of the challenges our families here are facing. We really focus on the urban core, but I'll get to that a little bit later. So I'm here with my partners, Kiersten, Cooley, and Carolyn, Schaefer, to tell you about what we're doing in this community. I'm going to start off with a broad overview of the program, how it works, some of the social determinants and the risk factors that we're trying to address for our families in this community, give you some of our statistics, some of the initial data that we found in year one of our program, and then Kiersten and Carolyn are going to tell you about some specific case studies and some families that they've interacted with and some of the challenges they've been able to resolve. Okay, so in a nutshell, Healthy Homes Des Moines is a home-based asthma intervention program. We use a model of 6 home visits where we're getting directly to some of the sources of a child's asthma. So if you think about a child getting sick repeatedly and going to the doctor can treat the symptoms in the office, give them a prescription, but then they're going back home into an environment that isn't healthy. The indoor air quality hasn't changed at all since this child visited the doctor. This is what we're trying to change. So what we've done is we've partnered with 3 hospital systems locally here in Des Moines, and they actually refer the patients at the highest risk to our program. We go into the homes and we see what's causing some of the problems. With Kiersten, we are able to address some lifestyle and behavioral issues, provide some asthma education for our families, and leave them with some initial steps of things that they can change. And then Carolyn will do an environmental intervention, and she'll go around and she'll look at some of what is in the home that may be causing the problems, and she'll talk a little bit more about that later. They then generate a repair report, and we go in and we actually fix environmental conditions. So we do moisture repairs, we've replaced roofs, we do a lot of plumbing things, even ripping up old carpet that is a harbor for dust mites. So we got started, as I mentioned, about a year ago with a Build Health Challenge grant. This is a national grant. It's a consortium of 5 national funders, so it's not federal at all. It's Robert Wood Johnson Foundation, Kresge Foundation, Colorado Health Foundation, the Advisory Board Company, and another one that I'm missing. Anyway, these 5 funders, they understood that there was a need to involve the health systems in their outreach to the community. So they developed this model where we'll give you $250,000 if your hospital matches and agrees to be a part of your program. So we were able to secure the funding in that way for this community, $500,000 over 2 years to address social determinants of asthma. So we're very excited to be started and up and running and sharing some of our initial year 1 data with you. This program wouldn't be possible without some of the key community partners you see on the bottom row here, Visiting Nurse Services, as I mentioned before, the Health Department, and the Polk County Housing Trust Fund. Now, the Polk County Housing Trust Fund is a really interesting partner, and I know this isn't necessarily about collaboration, but I do want to address the involvement of a housing provider and a housing funder in this community. The Polk County Housing Trust Fund receives money from the Iowa Finance Authority and from the county and some personal and private investors in the community to fund affordable housing projects. They give a lot of money to Habitat for Humanity as an example. They have an interest in affordable housing in the preservation of safe and healthy places for our families. So they were interested in this program because it was a way for them to measure their success of their dollars. So they've set aside repair funding for owner-occupied and for rental-occupied homes, which is really exciting. And that's the biggest reason why we're able to make the largest impact for our families in this program. Let's see. Many of you know the social and environmental factors, and this was something that Sally and Andrea touched on, but I wanted to share this graphic with you if you're not familiar with the Robert Wood Johnson Foundation's mapping of, well, they map, I guess, longevity. So this is just the Chicagoland area, and it shows here, depending on where you live, you know, you're gonna live 69 years on average here versus 85 here. And so just a change of zip code based on those neighborhood conditions, it can really impact your health in huge ways and really influence your risk for chronic disease. And we see that here in Des Moines urban core, and so I'm gonna tell you a little bit about that. This is a little bit of an overlap from your presentation, but some of the specific things that are common to the homes that we go in are pests, moisture and mold, and dust mites. These are things that our program is able to address and have shown hugely to impact the health of families. A recent survey of Des Moines showed that the prevalence of asthma in Des Moines' poorest neighborhoods is twice the rate for the state as a whole, potentially as the result of indoor air quality and substandard housing conditions. It's difficult to get the data that we need on a zip code or a neighborhood level, but this is about the best we could do when we were really doing some initial research for what the problem really was in Des Moines and what were some of the ways that we would be able to address it with this funding. So another thing we looked at was, this is a map of the Des Moines urban core. We looked at housing quality. This is based on the Polk County Assessor's site. So we zoomed in. All of the gray parcels that you see here are residences. All of the red that you see are residents in below normal condition. So you can see there's a really big problem here. I would say more than a third of the homes are redded out. Now, we can only speculate as to which homes have families in them and which homes may have an asthmatic child in them, but we can certainly see that we can impact the health just by impacting the housing of the families in this community. We say a lot, housing is a vaccine. If you live in a healthy home, you're more likely to be healthy. So this is some information on the Des Moines urban core, our target population here. So it's more than a tenth of the population of the city of Des Moines total. And you'll see here there's a big disparity of median household income. This is for a family of 4. So the homes that we're going into, these families on average are making around $30,000 for a family of 4. And you can just imagine how difficult it would be to live on this if you've got a couple of kids and you're talking about food, you're talking about your medical expenses, transportation. It's not a lot. So you can see some of the social, economic impacts that we could possibly impact with this program. And housing costs, absolutely. This shows you, it indicates a little bit of the disparity that we're talking about based on ethnicity and race. So Polk County as a whole is predominantly white, and then you kind of see some smaller breakdowns of ethnic minorities. But then you look at the urban core, it's quite different. So it's only about a third white, and it's about a third Hispanic and a third Black, and then there's a little bit of Asian, a little bit of other minorities. So we're talking about a lot of diversity that we know presents more chronic disease risk. Yes?
Sorry, can you define what the Des Moines urban core is versus the city of Des Moines?
Yes, that is my next slide. Segue. These are some of the zip codes around Des Moines, and so I'll kind of explain a little bit too. So this is the downtown area. This is just north of downtown. This is Drake over here. So you'll see what we've done is we've taken the referrals that we've received from our medical providers and mapped them out here. Most of the referrals, as you can see, are in the darker shade of purple. A lot here in the East Bay neighborhoods, because this is where we first piloted our program, the 6 months that we initially started, but also a lot in the south, just south of downtown. Does that help put it on a map, kind of what the urban core is? It's around 10. It's around 10 neighborhoods surrounding the downtown area. Yeah, and these are, this is where the city was born, right? So the homes are older, and the neighborhoods are older. The sidewalks may be crumbling, the streetlights may be in disrepair. There's, a lot of disinvestment and just aging infrastructure, really. So you can kind of see it could breed some of this chronic disease. And less people are on the street, people are feeling less safe, some of these things that you all mentioned. It's unsurprising that most of our referrals are from the urban core. This is some of the data that we've been able to extrapolate in the first year of our program. We do find we mostly receive referrals for boys, and the average age is between 6 and 7. The boys, the fact that we have 71% boys in this program, I think is interesting because it does sync up with national data that boys, for some reason, are more prone to develop childhood asthma than girls. But you can see that the ethnicity that we've received as referrals in this program looks quite similar to that of the neighborhood as a whole. Most of our children are on Medicaid. And one of the reasons why this is because we do have an income eligibility component that I forgot to mention to you guys. So backing up, our eligibility for this program is you have to be a child between the ages of 2 and 12. You have to make less than 80% of area median income, which means that if you're